In this introductory lecture, we're going to go over the Doppler shift as well as the Doppler equation. We're going to go over the Doppler imaging modes of color Doppler, power Doppler, and spectral Doppler, and we'll discuss the medical uses of each. We'll also discuss the pearls and pitfalls of Doppler ultrasound as well as how to acquire and optimize the Doppler image. Please keep in mind that Doppler ultrasound is a very complex subject, and by no means am I trying to create a video textbook here on the subject of Doppler ultrasound. The main goal of these introductory lectures is going to be to simplify Doppler ultrasound so that you can incorporate this into your point-of-care ultrasound exams. All right, let's look at the Doppler principle. Whenever there's relative motion between a sound source and a listener, the sound frequency heard by the listener differs from that produced by the sound source. This change in the perceived frequency relative to the transmitted frequency is called the Doppler shift. In this example here, let's say we were standing in the road. Here we've got an ambulance with its siren going. If the ambulance is stationary and we are stationary, there's no relative motion between the two, and a Doppler shift is not produced. However, let's say the ambulance is coming towards us and we're stationary. Since there's relative motion between the sound source and us, a Doppler shift is going to occur. Now, if we're moving towards a stationary ambulance, again, there's relative motion between the sound source and us, so a Doppler shift is produced. Lastly, the same thing would happen if the ambulance is moving and we're moving. Again, there's relative motion between the two, so a Doppler shift occurs. Just briefly looking at the history here, Christian Doppler was an Austrian mathematician and physicist, and he's the one who's credited with being the first to publish this principle, and this was back in 1842. In diagnostic medical sonography, Doppler is primarily used to pick up Doppler shifts that are obtained when echo signals are picked up from moving reflectors. And what we're talking about here is movement of red blood cells within a vessel. Clinically, that means we're going to use Doppler ultrasound to assess, is flow or pseudoflow present or absent? What is the direction of the flow? What is the velocity? And what is the vessel type? In the last slide, I used a couple terms I want to make sure that we're all on the same page with. One is flow versus pseudoflow. Now, from a purist standpoint, flow refers to movement of red blood cells within a vessel, while pseudoflow refers to movement that is not associated with red blood cells within a vessel. An example of this would be assessing with Doppler the ureteral jets within the urinary bladder. Now here we have an example of pseudoflow. This is a transverse view of the urinary bladder, so we have anterior, posterior, patient's right, patient's left. Here's the anechoic urinary bladder, and within there intermittently you can see that we're getting a Doppler signal, and that's because of the urine that's coming into the urinary bladder. So we are getting a Doppler signal here because there is relative motion between the sound source and the transducer. But from a pure definition standpoint, this is pseudoflow because it represents flow of a fluid other than blood. What about velocity versus speed? We're mainly in Doppler ultrasound going to be talking about velocity. So whereas speed is the rate at which something moves, velocity is the rate at which something moves, but in a particular direction. Before we move further into the Doppler principles, I just want to briefly mention the Doppler modes that are used in diagnostic medical sonography. You're going to have color flow Doppler, color power Doppler, and spectral Doppler. Color flow Doppler is going to provide information regarding reflector and scatter velocities. So that means we're going to look at the speed of the red blood cells in a particular direction. So you can see here, we can look at the velocity maps here, and you can see above this line it's all a reddish color, and below is a bluish green color. These reddish colors indicate flow going towards the transducer, whereas these bluish green hues represent flow going away from the transducer. And we're going to discuss this in greater depth when we go into color flow Doppler a little bit more. Power Doppler briefly will provide information about signal strength, but not direction. So I don't know from looking at this, is flow going this way or is it going this way? But advantages of Power Doppler are that it's less angle dependent and it has an increased sensitivity for flow detection, and we'll discuss the significance of that in a little bit. Briefly, spectral analysis is going to be used to illustrate the distribution of frequencies in the Doppler signal. So before we dive into the Doppler equation, let's look at the Doppler shift again. In this top example, the reflector and the transducer are both stationary, so there's going to be no Doppler shift. In the middle example here, the reflector is moving away from the transducer, so there will be a Doppler shift, and it's going to result in a slightly lower frequency echo being received by the transducer because it's moving away from the transducer, while in the bottom image, the reflector is moving towards the transducer, so the Doppler shift that's produced will result in a slightly higher frequency echo being received by the transducer. So this brings us to the Doppler equation. So the Doppler frequency is going to equal, and if you look at the numerator here, 2 times the transmitted ultrasound frequency times the velocity of the reflector times the cosine of the angle between the transmitted beam and the reflector path divided by the speed of sound. So as the operator, you have the ability to manipulate a few of these factors. You can change the transmitted ultrasound frequency. You can change the angle between the transmitted beam and the reflector path. And we'll talk about the importance of this when we go through image optimization. Looking at how this relates in diagnostic medical sonography, you're going to have the Doppler frequency equaling 2 times the transducer frequency times the red blood cell velocity times cosine theta, which is the angle between the transmitted beam and the red blood cell path, divided by the speed of sound. Now, when you look at the cosine of theta, it's important to remember that the cosine of 90 degrees is 0. So if you have 0 in the numerator, your Doppler frequency is going to be 0. So looking at the Doppler angle relationships in a little more detail, the Doppler angle will definitely affect the detected Doppler frequencies. So the cosine of 0 degrees is going to be 1. The cosine of 90 degrees is going to be 0. And that's really important because during B-mode scanning, you were taught to scan as close to perpendicular to your target structure as possible. In Doppler, that's not going to work out because you're going to end up with 0 for your Doppler frequency shift. The cosine of 180 degrees is going to be a -1. So remember, if the incident beam angle is greater than 90 degrees to the flow, the cosine of the angle is negative, and this corresponds to flow directed away from the transducer. So let's look at an example here. We've got a linear 10 to 5 megahertz transducer. Let's say that we're scanning at a 5 megahertz transducer frequency, and we're interrogating these red blood cells that are moving at 1 meter per second. If we scan at 0 degrees to the red blood cells, which would be ideal but not a clinical reality, we're going to end up with the Doppler shift frequency of 6.5 kilohertz. Now, if we change the transducer angle to 30 degrees, we're going to end up with the Doppler frequency shift of 5.6 kilohertz. If we're at 60 degree angle, we're going to end up with the shift of 3.3 kilohertz. And if we're at 90 degrees, we're going to end up with a shift of 0 because the cosine of 90 degrees is 0. So the big take-home point here is that when you're scanning, you want to be at an angle of 60 degrees or less. When you start getting at angles between 60 and 90 degrees, the interpretive error is going to be much greater with each degree of increase of that angle from, let's say, 60 to 61 to 62. So you want to make sure that your interface angle is less than 60 degrees. Looking at this example here, we're scanning in a sagittal plane the carotid. So this is anterior, posterior, head, foot. You can see here we're at a non-perpendicular angle, so we are picking up color flow within the carotid. But you can see here when we're at 90 degrees, we get no flow, again remembering that the cosine of 90 degrees is 0. When performing B-mode ultrasound, where you're obtaining your grayscale anatomic imaging information, you're going to be using pulse wave Doppler transducers, which use the same transducer elements for transmitting and receiving signals. In Doppler ultrasound, you can use either pulsed wave Doppler transducers or continuous wave Doppler transducers. Now, for the most part, unless you're doing high velocity interrogations in echo or vascular labs, you're going to be using pulse wave Doppler transducers. And it's important to understand the difference between the two. Since you're going to be predominantly using pulse wave Doppler transducers at the bedside, it's important to understand their disadvantages. The primary disadvantage of the pulsed wave Doppler transducer is going to be that you're going to get inaccurate measurements of high velocity signals. When you're dealing with very high velocity signals, such as in an echo or vascular lab, you're going to use a continuous wave Doppler transducer. Another disadvantage of the pulse wave Doppler transducer is that it can incorrectly display the direction of an echo and put it in the opposite direction. And this is referred to as aliasing. And this is a key concept I want to go through before we move on to the different Doppler modes. We're going to be discussing aliasing in much greater detail in the other videos within this series, but this is such an important concept, I just want to briefly go over it in this video. So aliasing is going to occur when the sampling rate is too low in comparison to measured blood velocity. A term you're going to hear a lot of is the Nyquist sampling rate. What this means is that the Doppler signal must be sampled at least 2 times for each cycle of the signal. And what you can see in this example here, we're sampling at a rate that is below 2 times the frequency. And what this is going to do, it's going to result in the image display wrapping around, producing an apparent reversal of flow direction. Aliasing, you have the ability to eliminate that by increasing the sampling rate or decreasing the transducer frequency. And we're going to go over this in much greater detail during the other videos on Doppler image optimization, but I just want you to have a basic understanding of this concept. Let me give you an example that may help you to better understand aliasing before we end this video. This was explained to me as a great example many years ago, and I've continued to use this over the years, and I think it really helps people to understand this aliasing concept better. Think about somebody who's dancing under a strobe light. Now, if the strobe light is flickering at a rate that's half their dance movement speed, it looks like they have a very chaotic movement pattern, and it's very hard to trace their dance movements because of this slow flickering of the strobe light. But as you increase the flickering of the rate of the strobe, it becomes clearer as to what their dance movement is or their rhythm is. And that's because you have to be sampling at least half of that movement speed. Anything less than that, and you're going to end up with this chaotic pattern, which in diagnostic medical ultrasound is aliasing. This concludes the Doppler instrumentation video. In the upcoming videos in this series on Doppler ultrasound, we're going to go over how to specifically acquire and optimize color Doppler, power Doppler, and spectral Doppler images. Color flow Doppler imaging. Information is going to be provided regarding reflector and scatterer velocities. Additionally, information is going to be provided regarding flow direction. So if you look at the color and velocity map here, you can see that there are reddish hues above this bar here, and that there are blue and greenish hues below the bar. So by traditional orientation, red is up on top here, and this means that the flow velocity is towards the transducer, and below, these bluish green hues represent flow velocities going away from the transducer. So by knowing that, you would be able to look at this image and decide whether this vessel is going from left to right or right to left. And by the end of this video, you'll be able to easily accomplish this. In color flow Doppler, there are some key limitations that you need to be aware of. Number one, this modality is highly angle dependent. So if you think back to the Doppler equation, the cosine of theta, which is in the numerator, if you have an angle that's 90 degrees, then the cosine of 90 degrees is going to be 0. So that means your Doppler frequency or shift is going to be 0. So to translate that into real-time scanning, you need to make sure that your angle of interrogation of the vessel is not 90 degrees. Ideally, you'd like to be at a 0-degree angle, but that's not clinically possible. So in real-world scanning, you want to have an angle that's 60 degrees or less. You also need to consider the possibility of aliasing, where you have an incorrectly assigned flow direction. And remember, that has to do with your sampling rate. If you take the frequency of the Doppler signal, you need to be sampling it at a rate that's twice that frequency. If you're sampling it at a rate that's below that, you're going to get inappropriately assigned flow directions. Think about the analogy I gave you in the Doppler instrumentation lecture of the strobe light and the person dancing underneath it, and how interpretation of the dance movements is directly related to the frequency of that strobe light. So just keep that in mind. Another limitation of color flow Doppler is the inability to display the entire Doppler spectrum in the image. And lastly, you can get artifact caused by noise. In B-mode imaging, echoes from a single transmit pulse are all that's necessary to produce the B-mode dots along each beam line. Now, this is in contrast to color Doppler, where multiple pulse echo sequences are needed to acquire the echo data along each beam line. It often takes 8 to 10 pulse echo sequences to make up a pulse or color packet for each color beam line. Now, this can help to explain the decreased sensitivity with color flow Doppler imaging. In flow velocity determination, color Doppler reports average velocities or mean velocities. Phase shift autocorrelation is the best known technique for calculating these mean velocities. It's important to remember in color flow Doppler, unlike spectral Doppler, which we'll be talking about in a separate video, your calculations of velocity are semi-quantitative at best. Let's take a look now at the anatomy of the color flow Doppler image. So here we have a sagittal view of the carotid artery. You can see first our preset. We're appropriately using here the carotid artery preset. Remember, the use of the correct preset is really vital since most of the other calculations will be usually in the correct range if you're in the right preset. You next are going to look for your color and velocity bar. You have that here. Here you've got your velocity scale right here from a positive 25 to a minus 25 centimeters per second. And you can see the color assignment here. Above the white line here, you've got flow directed towards the transducer, and these are assigned reddish hues, whereas flow velocities away from the transducer are given a bluish to green hue. You've got your color box here. It's within this box that the Doppler interrogation occurs. So you want to make sure that you have an appropriate sized box that's appropriately placed on the screen. You've got your transducer frequency. Remember, you want to use the highest frequency that'll allow you penetration to your target structure, keeping in mind that if you do experience aliasing that is difficult to correct by changing your pulse repetition frequency, you may need to decrease the transducer frequency. You've got your Doppler gain. Just like during your B mode image, you can control the gain. So you're going to turn the Doppler gain up until you see artifactual signals occur. Then you turn it back down until those go away. And usually at that point, you have an optimized image from the perspective of gain. You also have the ability to control the wall filter. Now, usually these are represented as low, medium, and high filters, but sometimes depending on the manufacturer, they may be assigned numbers. But basically, a high filter means that you're eliminating low and medium flow velocities, which if you're scanning a higher flow vessel, such as the aorta, that would be fine. But if you're scanning a low flow vessel, such as an intraparenchymal testicular artery, you wouldn't want to use a high filter because you're going to eliminate all the information you're trying to obtain. So let's start from the beginning and go through image acquisition and image optimization, and along the way we'll discuss some of the physics principles that pertain to each of these settings. I just want to emphasize that it's really important to both correctly acquire and optimize the image, because failure to do so could lead to the presence of Doppler artifacts that could result in incorrect clinical interpretations. You may end up with color in the absence of true flow. You may end up with absence of color in the presence of flow if you have incorrect settings, and you may have incorrect assignment of flow direction and flow velocity. First and foremost, make sure that you use a correct preset and you choose the appropriate transducer. For superficial vascular structures, we're going to use a high-frequency linear transducer. And in the examples here, we're going to be using the common carotid artery, so we're going to be using a high-frequency linear transducer. Just like with B-mode imaging, make sure that you appropriately select the transducer frequency. Keep in mind that the higher the frequency, the better the resolution, but less penetration. You ideally want to use the highest frequency that will allow you penetration to the level of your target structure. But keep in mind that if you have aliasing, one of the options is to decrease transducer frequency. You can do that in addition to increasing the pulse repetition frequency. Let's take a look now at scanning techniques, because this is the heart of everything. Keep in mind that the Doppler angle is going to be essential. That when you look at the Doppler equation, you've got the cosine of theta here in the numerator. So the closer you are to 90 degrees, the less information you're going to get. And when you're at 90 degrees, that number is 0, so you get no information. Here's a color flow image, a sagittal one of the carotid. So this is anterior, posterior, head, foot. And you can see that there's no true flow being represented here because we're at 90 degrees. So here you could see that with this transducer directly over the carotid, interrogating the RBCs and their velocity at 90 degrees, we're going to get no useful information. So how do we correct for this? Here again we have a B mode image, a sagittal one of the common carotid artery, so anterior, posterior, head, foot. Here you can see the common carotid artery. So again, knowing that we don't want to be directly at 90 degrees since we're going to do color flow Doppler interrogation, one of the transducer manipulations that we can do is called rocking. And you can break that down into the heel and toe maneuver. And so just think of it like a foot. So here's the transducer on the neck. So by bringing it back this way, it's the heel maneuver. And bringing it this way is the toe maneuver. And you can see how that changes the angle that we're visualizing the common carotid artery. So this would allow us a better opportunity to obtain color flow Doppler sampling. Another option that you have is to steer the color box. And this is the same image here where we're scanning at 90 degrees to the common carotid artery, so we're obtaining no useful Doppler signals. But here, without changing the angle, remember on the previous slide that we did the rocking maneuver using heel and toe to change the angle. Here we haven't changed the angle, but we did change the color box angle by steering it. Usually you have the ability to steer from about a minus 15 degrees to a positive 15 degrees. When you're steering it, how do you decide which way to angle? So what you want to do is take a look at the vessel and its angle. Think of this color box as a pointer arrow. And you look at the vessel and you look for the part that's the most superficial. And you place this part of the color box there, acting as the pointer. I think that's the easiest way to remember this. So to obtain the correct Doppler angle, it's really going to be a combination of both transducer rocking as well as beam steering. Since you can't steer the beam more than 15 degrees in either direction, it's really not going to be a sole solution, especially when you're dealing with the carotid artery, which normally your interface is at about a 90-degree angle. So now you've already optimized your B mode image. You've got a good view of your target vessel. You've appropriately rocked the transducer to obtain a good angle. You hit your color box or the color button. So now you've got your color box on there. You've steered the color box appropriately. Remember, superficial, deeper. Use this as a pointer arrow so you steer it in this direction. But now the question is, how do you size the color box? You can make this or keep this large, or you can make it very small. You want to make sure that you don't have the color box too big, because basically now you're asking the machine to obtain Doppler information from this entire area. So the larger the area you're going to ask it to obtain Doppler information from, the slower the frame rate is going to be. Remember when we were doing B mode scanning, we talked about how the more focal zones you place on the image, the slower the frame rate. Essentially the same thing happens here. So it's kind of a balancing act. You don't want to have the box too big. You also don't want to have the box too small. Here you can see that this box is just obtaining Doppler information from a very small area over the course of this common carotid. Here we have the box more appropriately sized, and again, it's appropriately steered, superficial, deep, and there's your pointer arrow on the box right there. Next, you're going to want to make sure that your velocity scale, or your pulse repetition frequency, which is the sampling rate of the Doppler signal, is appropriate. Remember, if you're sampling at a rate less than twice the Doppler frequency, you're going to end up with aliasing, which you don't want, because that means you're going to have inappropriately assigned flow directions. And you can see that's what's happening here. You've got blue is directed towards the transducer, red is the color directed away. Here you can see that you have a lot of ambiguous flow directions, and that's because of the velocity scale being inappropriately set. Keep in mind that your preset will usually put you in the right range based on each blood vessel, but here I intentionally took the velocity scale down to create aliasing. Here we have another sagittal image of the carotid. So anterior, posterior, head, foot. You can see we've got the common carotid here, and we do have it angled a little bit. We probably could have rocked the transducer a little bit more to get a more appropriate Doppler angle. You can see we've got the color box here. It seems to be appropriately sized, and it's steered, remember, superficial, deep. There's your pointer arrow. But notice, here comes the presence of aliasing, and that occurs as we drop down the velocity scale. And that goes away as we raise it up. Notice another thing here. On the last image, the blue box was on top and red was on bottom. And as I previously said, traditional orientation is that you have red on top and blue on the bottom, but you have the ability to control this. You can switch this based on your own preference, so you have to be careful that, depending on who was scanning before you, this box may be flipped around different from what you're normally used to. So just keep that in mind and always look at this for your reference. One more slide on aliasing, just because it's a very important topic. To eliminate it, increase the pulse repetition frequency or the velocity scale, or decrease the transducer frequency setting. Normally this is going to be your mainstay right here. This may be a secondary option, but here you can see increasing the velocity scale eliminates the aliasing. Let's now look at Doppler gain. Here again, sagittal view of the common carotid artery. Not the best rocking job of the transducer, but we do have the color box steered. So you would expect that we would see something here, but we're not seeing any flow. Does that mean that flow is absent? Well, if you take a look here, I've got the gain, the Doppler gain, turned down essentially all the way. And that's why we're not seeing any flow. So you have to make sure that the Doppler gain is appropriately set. And even if you're in the correct preset to begin with, this is one of the buttons or knobs that you're going to have to adjust, just like you do during the B mode scanning. And you can see here now, we're increasing the Doppler gain, and you can see that eventually it gets too high, and we get artifactual signals. And just like with B mode gain, once you start getting those artifactual signals, you come back down till they disappear, and then you're for the most part optimized. And here you can see numerically that we're increasing the Doppler gain. Wall filter is another important control to keep in mind. By increasing the wall filter, you're going to remove the lower velocity signals. So if you're dealing with a low flow structure or venous structure, you want to keep the wall filter low. And here's an example here of a sagittal view of the internal jugular vein with the wall filter set low. You can see that there's bleeding over the side here. I could do a better job of adjusting the gain on this one also. But notice, without doing anything else other than increasing the wall filter to the maximal high setting, you can see that I removed all of these lower velocity settings. But I just want to emphasize, you must be careful when you're dealing with low flow structures that if you have this filter set high, you're going to eliminate the target signals that you're looking for. Now that we've covered velocity, let's look at how to determine flow direction, since this is the other key component of color flow Doppler. So step one in determining flow direction, we're going to want to look at our color bar, and we're going to want to look at the colors. So here we've got the reddish hues above the line, so that means that flow velocities towards the transducer will be assigned a reddish hue, with these lighter colors being the higher velocity signals. And the bluish hues, with the lighter blue hues being the higher velocity signals, will be directed away from the transducer. So now we take a look at our image here. We've got a vessel here. It's assigned the reddish hues. The box is steered. So now we have to figure out, is flow going this way or is it going this way? So the next thing we have to do is to determine the home or reference line. So remember I said to think of this color box when it's steered as a pointer. You've got that pointer area where the vessel is the most superficial. So what you want to do is draw a line down from that. If you forget about the pointer concept, another thing you could remember is take a look at the upper line here of the color box. Draw a line down from each corner. The line that does not intersect with any of the color signal is your reference line. So now we've got a home or a reference line. Next thing we do to determine flow direction is, since this is our home or reference line, this becomes where our transducer is. Even though we know we're scanning up here because this is the near field, this is the far field, but for the sake of determining flow direction, now that we've got our reference line, we can pretend that we've got a transducer here. So now we've got the reddish hues here, so that means, looking at this color map, that this is flow directed towards the transducer. So we can say on this image here that flow is going from the right to the left, and that's what we would expect because the artery we're evaluating here is the common carotid. Now let's take a look at another example here. We have two vessels here. One assigned a blue color, one assigned reddish hues. Now this is actually a duplex image because we've got spectral analysis below here, but we're going to ignore that for now. But we're going to do the exact same thing. We can see that the vessels go from near field to far field here. So the box is correctly steered. Here we've got our pointer arrow. So we drop down our line from here. Again, if you forgot about the pointer arrow, just draw down a line from this corner of the top line and draw a line down here. the line that does not intersect the color signal is your reference line. So we put our imaginary transducer here. Looking at the color bar, blue is coming towards the transducer, red is going away. So that would mean the flow in this vessel is coming towards the transducer, so it's going left to right, and flow here is going right to left because it's going away from the transducer. And that's what you would expect because these two vessels here, this is the internal jugular vein, so flow is going, because orientation is anterior, posterior, head, foot, flow is going from head down to the torso, and for the carotid artery, it's going from the torso up to the head. In the previous examples, we looked at how to determine flow when we were using a linear transducer, but what about a curvilinear transducer? So here we've got a sagittal view of a vessel. I won't say what it is at this point. And here we've got our curvilinear transducer, and you've got up to 256 crystals here that are independently firing, and because of this curved array, they're firing at different angles. So the first thing we do is we look at our color box, and you see that reddish hues are going towards the transducer and bluish hues are going away from the transducer. So here's our path towards the transducer. You've got one here and you've got one here. So looking at this, you've got the reddish hues here. This path is coming towards the transducer. Here we're seeing no signal here, and that's because remember the Doppler equation. Cosine of theta in the numerator, if that angle is 90 degrees, that's 0, so that's why we're not getting a Doppler shift or signal here. Now if you look here, here we've got flow coming towards the transducer, but this is blue, so this is going away. So this is coming towards, this is going away. So flow direction is going to be from the left to the right. Now some of you may be looking and going, wait a minute, you're in the carotid preset, so flow should be going this way towards the head. And I probably should have blacked out this box here, but actually we were not scanning the carotid here. We were actually scanning the femoral artery, so flow is going this way, because remember, anterior, posterior, head, foot, so flow will go this way, and that's what our color map depicts here. This concludes the color flow Doppler video. Power Doppler differs from color flow Doppler in that power Doppler provides information about signal strength but not direction. Since velocity is not part of the calculation, it's going to be less angle dependent. That means that unless you're directly at 90 degrees, you're still going to be obtaining useful information. Power Doppler also has a benefit that it has an increased sensitivity for low flow detection. So this is clinically useful when evaluating structures such as a pediatric testicle or a thyroid or a musculoskeletal structure. A potential downside of its increased sensitivity for the detection of low flow states is that it's going to be very sensitive to either movement by the patient or movement of your hand holding the transducer. You get what's called the flash artifact, and you can see that here, just little movements of my hand creates this flash effect which will interfere with the clinical image and interpretation. Other key points to know with power Doppler are that the color map displays integrated power in the Doppler signal as opposed to its mean frequency shift. And you can see that here on the color map. Remember, as I previously said, power Doppler is virtually angle independent except if you're at 90 degrees. And lastly, the Doppler frequency shift information is not utilized because the display is non-directional, therefore aliasing is not encountered, so that's another plus. So how do you obtain and interpret a power Doppler image? Here we have two images here, both of the common carotid artery. So let's use this as the example that you wanted to obtain a power Doppler image of the common carotid artery. So just like you would for a color flow image, you're going to scan over your target vessel and optimize the grayscale image. Instead of hitting the color button on your machine, you're either going to hit the power or color power angio button, depending on your machine. This will give you, just like with the color flow, a box that will appear. And you have the ability, just as you did with color flow Doppler imaging, to steer the box. But remember, since velocity is not calculated here and this is amplitude driven, it's essentially angle independent unless you're right at 90 degrees. And you can see that here. Here we're not at 90 degrees. Here we're very close to 90 degrees, but we're still able to obtain a Doppler signal here. Now remember, when you look at the color map here, it's not giving you directional information like the color flow image gave you the velocity map. Here, this is amplitude driven with the weakest to the strongest signals being displayed, and you can see how that's mapped out, using the color map here. But again, it's not giving me any information about direction. Lastly, just as in color flow Doppler, you have the ability to adjust transducer frequency, Doppler gain, and wall filter setting. I went over this in detail in the color flow Doppler video, so if you haven't watched that yet or still have questions, I would recommend watching that video again after completing this video. So when you're evaluating a patient, how do you know whether to use color flow or power Doppler? Well, you're going to use color flow Doppler when information related to flow direction or velocity is needed, and you'll use power Doppler when evaluating low flow states or in conditions where flow direction and velocity information is not going to be needed. Spectral Doppler, you're going to have a quantitative graphic display of the velocities and directions of moving red blood cells present in the Doppler sample volume. So it's important to keep that in mind, that within a sample volume, not all the red blood cells will travel at the same speed or direction. The spectral analysis is going to be calculated by one of two methods, either fast Fourier transform or autocorrelation. Now if you look at this image here, this is referred to as a duplex image because you have both color flow imaging represented as well as spectral Doppler represented. And here you can see that waveform. To obtain a spectral analysis, on most machines you're going to hit the PW button, which stands for pulsed wave, and you'll do that after you have a good grayscale image of your target vessel. Now, I will normally do this in the duplex fashion, where as you can see here, on the top of the screen I have color flow imaging, and below I have the spectral analysis. It's going to be important when you're acquiring the spectral analysis that you have a good sample volume, so you want to make sure that your range gate is appropriately sized and in the middle of the target vessel. You're also going to want to make sure that you have an appropriate Doppler angle, so you're going to want to make sure that this line correlates with the flow of the red blood cells within the vessel. Here we have a duplex image of the common carotid artery, but instead of having color flow imaging here, we have color power imaging, and below we have our spectral analysis. Again, we have the range gate here with the sample volume being obtained in between these two lines, and we have an appropriate Doppler angle. Keep in mind that with power Doppler, information is amplitude driven and not velocity driven, so this does not give us information about flow direction. So in the other videos we've already talked about color flow and color power Doppler. So why do we want to use this clinically? What information can this give us? Well, first, we can quantitatively assess velocity within the vessel. We can also use spectral analysis to obtain a waveform signature. This can be used to help differentiate an artery from a vein. It can also be used to calculate out the resistive index, which is defined as the peak systolic velocity of blood within the vessel minus the end diastolic velocity within the vessel divided by the peak systolic velocity of blood within the vessel. Now, the resistive index signifies the resistance of the vascular bed distal to the interrogated vessel. So a low resistive index, you're going to see that in vessels that supply organs requiring constant perfusion, which would include brain, liver, kidneys, and placenta. The low resistance arterial waveform features a large quantity of forward flow continued through diastole. Now, high resistive indexes are seen in vessels supplying high resistance vascular beds that require intermittent or on-demand blood supply. Clinical examples of this would include facial, femoral, and superior mesenteric arteries. In these arteries, high peripheral resistance impedes diastolic flow at rest, whereas low peripheral resistance allows significant diastolic flow during increased activity. So here we can look at the spectral waveform in more detail. On this axis you have frequency or velocity, and on this axis you have time. You can see here that this is the peak systolic frequency or velocity, and you can see as you come down here, you'll end up then at the end diastolic frequency or velocity. So let's look at a clinical example here of two different spectral waveforms. Now, coming off the common carotid, you're going to have the external carotid artery that supplies the face and the neck, and the internal carotid artery which supplies the brain. Now, if you take a look at the external carotid artery and the internal carotid artery, their spectral waveform signatures are different. And this is what you would expect. You'll have a higher resistance here with less diastolic forward flow in the vessel that's supplying the face and the neck. But within the brain here, you can see that there is a greater degree of diastolic forward flow, and that's what you would expect in a low resistance vessel supplying the brain. So let's look for a little bit at how to optimize the image, and we'll first look at the range gate. Now, when you look at blood flow within a vessel, under normal circumstances, and we're not talking about an atherosclerotic vessel where there's turbulent flow, you're going to have normally a laminar flow. So there's going to be some degree of difference in the flow velocities within the vessel. So therefore, you're going to want to make sure that your sample volume, which would be represented between these two lines here, is going to be from the center part of the vessel. You want to avoid having a range gate that, especially on a larger vessel, that encompasses the entire vessel, because you're going to get a much wider display of velocities. And you can see this is what a spectral broadening is. You can see all this fill-in here in the waveform. Here we have a spectral analysis of the common carotid artery, and you can see that we're taking our sample volume from the central part of the vessel here, and we have an appropriate waveform seen below. On the same vessel, what we've done here is we've moved our sample volume over towards the side. And notice that the waveform is different. And notice that if we were trying to calculate out either the velocity or the resistive index, we're going to get a different value because of where we've sampled the velocities. So keep that in mind. Make sure that when you're interrogating these larger vessels, that you're obtaining the sample volume from the central part of the vessel. So we want to make sure when we're looking at Doppler angle that we have a correct angle. Again, you want to be scanning at 60 degrees or less but you want to make sure that this line corresponds with the flow direction of red blood cells within the vessel. So here we have a correct Doppler angle. Here on the same vessel, this angle is incorrect because this does not correspond with the true direction of flow within the vessel, so we're going to get incorrect information. Now what we've done here is we've gone from an incorrect angle to a correct angle. So what you see over time here is the change in this spectral waveform as we had an incorrect angle of interrogation to a correct angle of interrogation. So see, if we had done peak velocity assessments, we would have obtained incorrect data. The same thing if we had calculated out our resistive index. We already discussed wall filter adjustment in the color flow imaging video, but take a look what happens to your spectral waveform. Remember, you have the ability to adjust the wall filter from a low, medium to high setting. And when you're at a high setting, you're basically telling the machine that you're not interested in these lower and medium velocity signals, and those get taken out. And that's exactly what happened here. Here we have a low filter setting, and you can see the expected waveform of the common carotid artery that we're interrogating. But now notice, as we increase the wall filter from medium to high, that we lose all these low to medium velocity signals. So you can have a higher setting with higher velocity vessels, but remember, when you're scanning lower flow vessels, you have to have a low filter, a low wall filter, otherwise you're going to lose all the vital signals that you need to make a clinical interpretation. Let's look at what happens with adjusting the velocity scale. This brings us back to the dreaded aliasing concept. So you can see here, by having a sampling rate that's too low, we're going to get this wraparound effect. So what you need to do here is increase your sampling rate, which would be represented on your velocity scale. So that's an increase in your pulse repetition frequency. You can also decrease your transducer frequency, or you can adjust the baseline. You can see on this image here that here's the opposite end of the spectrum. You also don't want to have the velocity scale set so high that all your usable information is crammed into this little area. Here we've got a scale of, of about 400 centimeters per second, which is way too high for this common carotid artery. It would be much like on B mode scanning to be looking at a superficial foreign body in the subcutaneous tissue, but having the field of depth set at 20 centimeters. You also want to make sure that you have your baseline set appropriately, as you can see here, because what we have the ability to do is to raise this baseline, and you can see ultimately what happens is by raising it too high here, what I've done is I've created aliasing here. So make sure that you have your baseline appropriately set. Now let's take a look again in a little more detail at the waveform signatures. Now here we have a spectral waveform of the right internal jugular vein, and you can see the distinct pattern here of this venous waveform. It does not represent at all either a high or low resistance arterial waveform. And here we have a high resistance waveform, and this is from the common carotid artery. So you can see here you've got the systolic peak velocity, and here you can see you've got your end diastolic velocity, and you can see that there's less forward flow during diastole in this vessel, and that's what you would expect in a high resistance vessel. Here we have a low resistance vessel, the internal carotid artery, and here you can see the different spectral waveform. You've got your peak systolic velocity, here's your end diastolic velocity, and you can see that there's a greater degree of forward flow during diastole here, and that's what you would expect. Here's another low resistance vessel, And here we are scanning an intraparenchymal testicular artery, and you can see here you've got your peak systolic velocity, and you can see that this peak systolic velocity is much different than the peak systolic velocity of the internal carotid artery or the common carotid artery. And this is why your settings are going to have to be different here. When you're dealing with a low flow vessel, you want to dial things down. You want to make sure that you've got a lower pulse repetition frequency. You want to make sure that you've got your wall filter set at a low level so you don't clip out the desired velocities that you need to make a clinical interpretation. But looking at the testicle here, you see a low resistance waveform, which is what you would expect in the testicle. But now let's take a look at this testicle. So there is still flow present, and I'll tell you here that there's an abnormal appearance of the parenchyma of the testicle. Normally the testicle should have a homogeneous appearance to it. This has a heterogeneous appearance to it. And when you look at this waveform, there's a high resistance pattern here, and you can see that forward flow during diastole has been clipped off. So the question is, why do you have this pattern here? Now, this patient has testicular torsion, where the testy twists on itself and cuts off blood supply. Now, this occurs over a spectrum, and it can go up to 720 degrees, meaning that the testicle has twisted several times on itself, or it could happen at a lesser degree of twisting. So you can see this patient is on that spectrum, and so this is a supply-demand issue, that this testicle is now ischemic, meaning it's not receiving enough blood flow to adequately meet its needs. So if you look at this spectral waveform, this can be very helpful, that you can see that it doesn't have that normal low resistance pattern, and that's because during this spectrum of the twisting, you start to lose the lower resistance flow that occurs as that twisting continues to increase. And that's why you see here that you're losing that forward flow during diastole. During the hands-on scanning session, we'll go through a blood pressure analogy and show you how the waveform in the brachial artery is going to change as the blood pressure cuff is increased. In this patient who had a systolic blood pressure of around 100 millimeters of mercury, you can see that this waveform is dampened. It almost has a venous appearance to it. And you can see as we bring the cuff down that you're going to get the expected high resistance flow pattern of the brachial artery. And you can see here as we're inflating the cuff that the waveform is dampened to almost what looks like a venous waveform until it disappears. So we'll have the opportunity to play around with this during the hands-on session so that you can better understand the spectral waveform. This concludes the spectral Doppler video.